Hello and welcome to this video series on occlusion. My name is Dr. Devang Patel, and in this video we are going to discuss about function versus dysfunction, especially in relation to temporomandibular disorders. As the title suggests, we need to understand function of anything before we can understand dysfunction of that particular area. And because of that, we are going to discuss about function of temporomandibular joint, muscle of mastication, and dentition, and their overall relationship in order to create or produce temporomandibular disorder. So let's look at first temporomandibular joint and its anatomy. So as you can see in this photo, you have anterior capsular ligament which surrounds the temporomandibular joint. You have articular surface which is provided by the bone. You have superior and inferior retrodiscal lamina, which is then you have a retrodiscal tissue within that. Retrodiscal tissue is very important and very sensitive tissue, and because of that, many times patient comes with the pain when you have intracapsular derangements. And we'll discuss about that more in detail in later videos. You then have superior and inferior joint cavity, which is full with fluid, and that allows frictionless movement of the mandibular joint. You have superior and inferior lateral pterygoid muscles, which are also really important muscles to understand and because of their contribution to disc displacement or stability of the disc or temporomandibular joint. With regards to the ligaments, you have two types of ligaments, or you have two parts of temporomandibular ligament. One of the part is outer oblique portion, which limits the normal rotational opening of the movement, because otherwise the jaw will just drop down. So you need ligaments to restrict the opening and restrict the jaw falling apart. And this is in relation to any joint in our body. Then you have inner horizontal portion, and the main function of this ligament is to limit the posterior movement of condyle and the disc, to avoid moving condyle and disc really posteriorly and crushing that retrodiscal tissue. If you look at the temporomandibular joint, it looks something like this in a musculoskeletally stable position. We know that as a CR. However, because there are different definitions of CR, it's difficult to know, but in this case it's superior anterior position, where the condyle is then surrounded by the disc, and if the patient is in this position, their jaw is in a comfortable position. Let's look at the muscles of mastication and their function. So one of the main muscle of mastication is masseter muscle, and the function of masseter muscle is a mainly elevator. It elevates the mandible into superior but little bit anterior position because of the position of that the muscle. The other muscle is temporalis muscle, and temporalis muscle helps in moving the mandible in superior position, and these two muscles act together to move the mandible into superior anterior position, which is more musculoskeletally stable position. You also have a medial pterygoid muscle, which is also an elevator muscle, but also if it contracts unilaterally, it provides mediotrusive movement of the mandible. Then you have a very interesting lateral pterygoid muscle. Now the lateral pterygoid muscle is divided into two different muscles. So you have inferior lateral pterygoid muscle and you have a superior lateral pterygoid muscle. Now with regards to inferior lateral pterygoid muscle, it's really helping mandible to protrude. However, at the same time, working with depressor muscle, it helps mandible to depress as well. But if you want to test this muscle, which we'll discuss in a future video, you need to really do the protrusive movement, and you will be able to assess the function of this muscle. Superior pterygoid muscle is actually inactive when patients opening their mouth. It's only active when patients closing their mouth and making a power stroke movement, which is clenching or chewing. It is muscle which is attached to capsule and to the condyle. Although around 30 to 40% of the muscle is only attached to the capsule, most of the muscle, 60 to 70%, is attached to the condyle. It still helps in making sure that the capsule moves in harmony with the condyle and does not fall back where the condyle is moving forward. However, if there is a disharmony in that muscle, then that can cause issues with the capsules as well. So the third component is a dentition. And in dentition, as we discussed in previous videos, there are various reasons why the jaw cannot be in a CR or musculoskeletally stable position. Patient may have a slide, patient may have a pivoting contact, or patient might just have one contact, and which is not allowing the jaw to seat into more musculoskeletally stable position. However, that doesn't mean to say that if patient has a malocclusion, the occlusion is the factor of their TMD, if they have a TMD as well, because there could be patients who have a malocclusion, but their joint is in musculoskeletally stable position. If that's the case, then you need to really look at the other reasons for TMD, which we'll go through in a minute. So let's look at the function versus dysfunction. And if you see on the left hand side, you see joint in function and musculoskeletal stable position, whereas on the right hand side you can see the capsule has moved, the disc has moved forward. Now the disc moving forward not by itself is a dysfunction. It could be a functional displacement of the disc for some reason, but in many times when patients have pain, intracapsular pain, it is associated with some sort of a disc derangements. So let's look at the etiology of TMD. So if you look at the patient usually presents with a normal function, and then these are the 5 areas which can then disturb the function, which could be occlusal reasons, it could be trauma, it could be deep pain input, it could be emotional stress, or it could be parafunction. However, one crucial part which decides where patient's going to have temporomandibular disorder or not is patient's adaptability. And this is very well described by Dr. Jeffrey Oxen, and I would highly recommend you guys to read his books and follow him if you're really interested in TMD. But the adaptability of patient, which I have seen in my own experience as well, very crucial factor, because you have seen those patients who you know someone else, or you have left restoration high and they come back and there's no pain, whereas some patient you really meticulously adjusted occlusion is perfect, patient comes back and they have a very small tiny spot but they are in pain, and as soon as you remove that spot, patient feels much better. You have some patients who are really highly stressed job, but they're not showing any TMD diseases, or patients on a relatively less stress job, but even the smallest amounts of stress causes them TMD. So there are a lot of factors affecting or predisposal of the TMD. However, adaptability of the human being is very, very important. Let's look at these 5 factors a little bit more in detail. So occlusion has been very well debated in past. Actually, we believe that occlusion was one of the reasons main reason why patient had TMD, because that's what we see. We only see teeth most of the time. So because of that, we treated every patient with TMD with full mouth reconstruction, changing their position and making them musculoskeletally stable position by making CO equals ICP. And we realized that this is not the case. However, let's say if the occlusion is the case, it affects in two ways. It affects the position of the muscular orthopedic stability, and also the acute changes in occlusion can affect the TMD as well. So orthopedic instability, or the amount of force you apply to the jaw, can cause or contribute to TMD. Whereas if you left a restoration high, or patient has a high restoration, then that can also cause TMD. However, there is interesting study done where the students of the dental university were given intentionally reversible high restoration. And what we found that the student who had a history, once the high restoration was removed, student who had history of TMD, the pain still lingered on for some longer time than patient who didn't have history of TMD. And that again goes back to adaptability. Seligman in 1991 also described that, the patients with TMD or normal function, it doesn't really matter whether the patient has a non-working side contact or not. Both patient had non-working side contact, so it's not a crucial element. And that's why we need to really understand that occlusion may not be the only factor which is affecting TMD. So the other factor is trauma. And when we really look at the trauma, we think about macro trauma, when patients having a roadside accident or sports injury, or patient fell down and hit their jaw or somehow damaged the musculature. However, what we not realizing is a macro trauma, which is by bruxism, clenching, grinding. And this is very important for us to understand that when patient has this macro trauma, it is affecting in some patients and causing TMD. We have emotional stress, and there are different types of stress. The stressors causes fight or flight response. And many times a human being have two ways to really deal with this stress. They can deal with this stress externally or internally. Externally by throwing things, shouting, hitting, or reacting to the stress. However, internally, if they are not reacting out loud, they are damaging internally, and these patients can present to you with irritable bowel syndrome, hypersensitivity or hypertension, and they can also come with a stiff neck or jaw pain muscles. And you need to really understand how the stress affects the muscles. So when you have increased stress, it excites the adrenal axis, and what that does is it affects the gamma afferent system, and it also activates it. Because of that, the muscle spindle stretches, and because of that, less stretching of the overall muscle is needed for some stimuli. And because of that, increased muscle tonus and sensitivity to external stimuli, the muscles are already all stretched and toned, and that causes muscle fatigue and also increases interarticular pressure in TMJ and causes a TMD. Now, it doesn't happen on all the patients. Again, you need to understand the adaptability of the joint and in combination with other factors. With regards to increased gamma afferent activity because of the stress, patient can also develop non-functional habits, such as patients start clenching or grinding their teeth or biting their nail which is not related to function. But this is because of the increased activity of gamma afferent system. The other part or other factor which can cause TMD is deep pain input. And this is something not very well understood or very well described or taught. Deep pain input means that you can have some musculoskeletal issues, you can have neural, vascular or visceral structure which are in pain, and then the pain is migrating and causing the TMD. Classic example is patients with pain in the tooth. And because patient has that painful tooth, the muscles are contracting. And because of that, patient comes to you with limited mouth opening. And sometimes the pain is gone, but the mouth opening is still limited. And if you don't treat that tooth, you will never be able to treat the patient's TMD, which is secondary to the pain. And that's why you need to really understand where the pain is originating from. The final factor is parafunction, and this is something which we are used to see and used to describe and discuss with patient. So what are the types of parafunction? So you have a daytime parafunction where patients really lowering their teeth in a static relationship. So they are not dynamic, just a static relationship and clenching, mainly as a clenching. What happens is the force during this time, because patients awake, is much less than bruxism. So what is the other activity? Nocturnal, nighttime activity. And this is the main one which is more destructive. Having said that, if patient has a daytime parafunctional activity, you really need to educate patient in order to avoid clenching and grinding their teeth. And we will discuss about that in our treatment video. So nocturnal grinding, it can be a single episode such as clenching or rhythmic episode, which is bruxism. It is related to parafunctional activity in sleep because it's nocturnal, patient sleeping. Most of the activity is eccentric, as we discussed previously. What we understood from the different research is malocclusion has got little to do with the bruxism. However, increased emotional stress is one of the main reasons why patient brux. It's not the only reason, as I said, it's quite complex, and you need to really consider all the rest of the contributing factors. The occlusal appliance can reduce the activity for short term. However, if you look at the long-term results of occlusal appliance, bruxism cannot be eliminated. You can only reduce the activity, but if patients wearing the appliance for really long term, patient starts having more bruxism again because the jaw gets used to with that and just overcomes your appliance and just kicks in the old habits again. And that's why it's important to not ask patient to wear appliance for 24/7 every single day, because patient will get used to it that and start grinding and clenching on the appliance. So that will still protect the teeth, but it will not get rid of the tense muscles. And there is no correlationship found between TMD and pain. And this is, you must have seen this in your clinical experience, where patients come to see you with, very flat, short teeth, but not in pain. And this is suggested by evidence as well. So as you can see, there are lots of factors contributing to TMD. And what you need to understand is they don't work individually. Many times you have one factor overlapping the other factor. You have primary factor as one factor and the other factor as a secondary factor. So if you don't treat the secondary factor, primary factor, and just treat the secondary factor, you will not be able to treat the patient. Also, adaptability is very, very important. And that's why you need to really keep that in mind. Patient's history, how patient has reacted to previous treatment, and decide on the future treatment depending on that treatment. So I hope you found this useful. As I reiterated, understanding function is very, very important when you want to understand dysfunction. So in the next video, we will discuss about examination and how to differentiate between intracapsular and muscle disorders.